as we start. First of all, I just wanted to sort of introduce you all to Summer Seath, who's our sort of our senior admin from Lancashire South Cumbria Trading Hub, who's very kindly taken up the sort of Lisa Horn's mantle, and is going to take minutes and has been sending out all the invites and has been dealing with all my sort of incessant emails for the last well, I was going to say the last day, but it's been a lot longer than that. But she's been absolutely brilliant. So welcome to Summer. And again, thanks very much, Lisa, for doing all the minutes up until now. That's been really helpful. There's a couple of things we just wanted to update you on. There's the sort of the NHS Careers website, which has been launched. If you may have noticed, if you tried to follow the link, that it didn't take you anywhere because I can't spell the word career. It only has one R in it, not two. Well, not two in the middle anyway. So this is a really brilliant sort of website which has been developed again by Lancashire and South Cumbria, and it's really looking at sort of improving sort of recruitment, retention and development of our sort of workforce. And there's loads of really great information on there. It's well worth looking at. There's got loads of stuff about apprenticeships, placements, sort of employment programs. So there's also sort of dates with events, so apprenticeships and sort of career insights and that sort of thing. So it's a really great site. It's a soft launch at the moment, and it's going to be populated as we sort of goes along. There has been a request for them to have a sort of a day in the life of a first contact practitioner. So, you know, whether it's a video or whether it's using something like a HoloLens or even a case study, anything just that they can put on there so people can get an idea of what does FCP sort of really mean when you're actually there, you know, in practice. So if there's anybody who wants to do that, then let me know. So just email me. And I'll put you in contact with, I think it's Ruth Keeler, who's and Ian Hooker, who've been sort of setting up who set up the careers platform. The other thing which I wanted to sort of highlight was sort of the digital literacy tool, a self-assessment tool. So this is like an online questionnaire which is to sort of identify sort of training needs, and then it kind of links you with sort of the HEE kind of Health Education England sort of learning resources. So it identifies, you know, if you've got problems around sort of specific software or specific sort of IT issues. Again, it's been launched through Lancashire South Cumbria, are sort of one of the early uptakers of that. And it's really a case of just getting in touch with your local digital champion, and they should be able to put you in touch with it. We will attach sort of a PowerPoint presentation to the minutes, which so you can have a little look in a bit more detail. But again, really sort of interesting sort of way. If there's anything, you know, it can be used for anybody in primary care, and a great way of sort of identifying what sort of things you need to sort of develop. Oh, what I was going to say as well around Summer, if there's anybody who's been sort of joined the group who isn't on our mailing list, they've just heard through sort of other colleagues, then if someone can put her email address in the comments, then just contact us directly, and she will put you on the mailing list. So that's kind of just a few updates of some of the things which have been happening fairly recently. And then I just want to introduce you all to sort of Lindsay Hector, who's our AHP sort of PEF at the AHP faculty. So the faculty has very recently sort of launched. I think it was on AHP Day, which was in October, 14th of October. So that was the official launch date. There's been quite a lot of work which has been going on in the background, probably since sort of around sort of February, March of this year, I think. But the official launch was last month. And Lindsay's just going to sort of give a bit of an introduction. I think she's going to play a really great video and then do a little presentation and answer any questions. So I'll hand you over to Lindsay, if that's okay.
Hi, yes. So we'll start with the animation because that just explains the team, if that's all right, Summer.
Can somebody shout if they can't hear it, if that's okay? Just want to make sure you can hear it.
Hi everyone, welcome to the Lancashire AHP faculty launch today, but also happy AHP's Day. My name's Nick Lane. I'm a physiotherapist by background. I'm the Chief AHP of Blackpool Teaching Hospitals, but I'm also the newly appointed Lancashire South Cumbria AHP Faculty Chair. I think what most excites me about the AHP faculty and the concept of the AHP faculties across the country is that it brings together people with passion, drive, and the skills and experience to start to work together to look at some of our wicked AHP workforce problems, things that we can't solve on our own in a provider setting, and that absolutely require us to come together, be that at a system, a region, or a national level. And from the work that I've done with the faculty so far, I think we've got some absolutely brilliant people in the room across health, social care, but also from our HEIs and wider system partners. So what I'm really looking forward to is bringing those people together and supporting them to start to resolve some of the problems that we know we've had from a workforce perspective for a long period of time, and to support the delivery of some plans to improve the sustainability of our workforce across the region.
Hello, welcome to the launch of the Lancashire and South Cumbria AHP faculty. My name is Liz McMullen, and together with my job share colleague Patsy Probert, we are the AHP Workforce Lead. We both have experience working as Chief AHP Lead in the community and acute sector. As post holder, we have responsibility to lead a workforce supply and transformation programme that delivers both work transformation priorities for health education in England, as well as across the ICS. The focus of our portfolio is closely aligned to the allied health professions workforce, working closely with the AHP Council and Regional Head of Allied Health Professions on a variety of programmes, including placement expansion, return to practice, repair and careers.
Hello, my name is Patsy Probert, and with my colleague Liz McMullen, we are the Lancashire South Cumbria AHP Workforce Lead. I'm an occupational therapist by profession, and most recently Chief AHP in Community, Mental Health and Learning Disability sector. Together, we have responsibility for delivering a workforce supply and transformation programme across the Lancashire South Cumbria system that also supports Health Education England workforce priorities for AHPs. We work closely with HEE AHP regional workforce leads, chief AHPs, and the wider membership of the AHP Council and faculty, including local universities, careers leads, workforce and education leads, and AHP clinicians across all providers. Some key programme priorities for us are support and development of AHP apprenticeships, development of advanced clinical practice for HPs, career development for our support workers, and collaborative placement coordination across our system.
My name is Sarah Unthank. I'm currently supporting the Allied Health Professional faculty as an Allied Health Practice Education Facilitator, 1 day a week alongside my other roles within the AHP workforce and placement expansion projects. I work for East Lancashire Hospitals and I am a physiotherapist in urgent care by background. This AHP PEF role is supporting the Lancs and South Cumbria system as a whole, and we aim to work as a group but collectively to help to support all the different trusts across the ICS with both students and clinicians. My name is Jane Miller and I have taken up this new role as an AHP Practice Education Facilitator within Lancashire and South Cumbria. I'm a therapeutic radiographer and my focus will be to establish best practice standardisation across the trusts for both therapeutic and diagnostic radiographers. I've taken on this role part-time and will continue my current role as one of the operational leads over protons at the Christie NHS Foundation Trust.
Hi, my name's Lindsay Hetko. I'm an AHP Practice Educator Facilitator, which is PEF for short. I currently work for Lancashire and South Cumbria Healthcare Partnership. My background is I'm an occupational therapist, although I've worked as a team leader across OT and physio in a rehab hospital for the last 8 years. The current roles and responsibilities that I have as an AHP PEF is supporting the Lancashire and South Cumbria system, establishing best practice and trying to work towards standardisation across all the trusts that we support.
Hi, my name's Sonia Spencer. I'm an AHP PEF for Lancashire and South Cumbria Healthcare Partnership. As an allied health professions practice education facilitator, my role is to support Lancashire and South Cumbria and our AHP faculty to facilitate system-wide collaboration across professions between health, care and education providers. We enable idea and resource sharing, alignment of priorities and best practice across systems such as workforce, education and training. I'm a physiotherapist by background, and I've worked in and led fabulous multi-professional teams in acute and tertiary centres. My main specialty for the last 12 years has been MSK and orthopaedics. I'm passionate about AHP and support worker development and role promotion.
Okay, so that was, excuse me, an introduction to the faculty, and I'm just going to talk through a short presentation just to highlight some of the aspects that were discussed during that. So Summer, if you're able to pull that up, I know you're flipping between things. So the faculty was established, like you say, Liz and Patsy came into post sort of recurrently in May. So we have only really been established. I came into post in August, so we've had a lot of sort of background work to develop the work plans, start the networking and things like that, and progress that on really, because Patsy and Liz are only part-time. I am the only full-time member of staff, so we're having to sort of work our way through the networking aspect and linking in with the appropriate people at the right time. So if we just start the presentation. All right.
Sorry, I think somebody stole the control from me and then closed it down. I think someone accidentally pressed the button. There you go.
Okay, thank you. So with the, like I say, the launch, there is the full presentation of the faculty launch and the links there. So I'll get Phil to send out the slides later, and then if you want, I mean, the full thing is about 50 minutes long, so you know it can be quite time consuming, and obviously I'm going to cover those brief bits here. So next slide, please. So although we are hosted by East Lancs Hospital, and that's why we have East Lancs on our email and obviously on my beside my name here, we do cover the whole system. So the aspect is to look at the best practice across the system with all the AHPs, all the 14 professions, and we want to inspire and to motivate the AHP community and try and help restore it after the COVID impact of it all. So our 4 main aims for the next 6 months, because the faculty was only established for a year, so up until April, and then we'll renew our aims, is to support the development of safe and effective care across the system, promote the careers, and Phil stole some of my thunder about the website. That's absolutely fine. Promote the diversity and optimise retention to sustain the growth of the workforce, because demands are increasing. So we do have to work on those placement expansions as well. And then obviously having a clear governance line for the faculty to feed into all the other subgroups and then into the People's Board eventually. Next slide, please. So this is the geographical area that the faculty cover, and we've got the 5 trusts, NHS trusts within that. We've also covered primary care, the independent sector and the voluntary sector, and we cover, like I said, the 14 professions across anywhere. So we're quite happy to share best practice, work collaboratively across the teams and support the sharing of items. We don't want people to be siloed and doing lots of work independently when somebody else across the system may have already done it. So we're trying to improve those links to feed into to us, to then us be able to cascade information out. So the next slide, please. So this diagram gives you just a brief overview of where the faculty feeds into. So we've currently got 3 subgroups: careers, and then the placement expansion and the coordination subgroups. So they've been working quite nicely behind the scenes from about April last year, looking at the different approaches to placements, as well as taking extra students on the same placement. And like Phil mentioned about the careers, looking at how they can do a calendar for careers. So looking at people who probably 14 to 18 looking to go into a health profession, but being able to guide them, because we found previously people went to universities on the wrong course for them and then would drop out. So actually having that education and those discussions around it, hopefully they'll go onto the right course straight away. Obviously looking at the repair, so the retention side of things, and attrition is really important to us. We want to get those people within the career and maintain them. And then all this information feeds back to the national and regional meetings, and then back up into the people board. And obviously the council will feed down any different work streams they want us to work on. So the next slide, please. So these are the current work streams that we've briefly discussed before. So like we say, the careers. So we're looking at enabling more meetings with the students, trying to do some face-to-face with schools as well. Looking at promoting the apprenticeships, we're currently supporting the OT apprenticeship at the moment and looking at developing that, because that course should start in March 22. Physio One, they're just looking at procurement of their Northwest provider, so we'll be supporting that and trying to have a collaborative approach, so the apprenticeship placements are all sort of in sync and the support's there for them. Looking at the support workers as well. We're trying to, the workforce development teams within some of the trusts are looking at the support workforce. We want to look at their progression and their education as well. So we're trying to do that on a system-wide approach. The pre-registered placements to expansion, so trying to increase those placements, because the demands with the extra courses coming on and having apprenticeships, we really need to increase those placements and looking at different areas. So maybe even looking into the private sector and the voluntary sector. Return to practice, we've been tasked with quite a big request to get the return to practice people back, but it's just getting them interested being back. I think we had a big influx with COVID, but that's tailed off now, so we just need to sort of restart that, and we just want to make sure that the systems and organisation have a standard approach. And then also looking at increasing the network for the BAME staff, widening their partnership. So we're linking in with the national and regional teams at the moment to try and expand those side of things. Obviously, it's not an independent sector. We want to have that stream within all our work streams. And looking at the clinical advanced practice as well. So we're linking in with the regional and national approaches for that. And then looking at preceptorship, we want all new starters to be able to go through a course of a preceptorship to help with retention and make sure that they're happy within their organisation and their profession. So next slide, please. So this, I've just put this on, obviously, because the emails weren't on the animation, but please do contact us. Like I say, I am the only full-time member of staff, so sometimes it might be easy to come via me, and we are hoping to get a central email that we can link up. But please contact anybody. If you want to communicate with us and have an understanding of what's currently going on, we're quite happy to network and put you in contact with the relevant people. Next slide, please. And then these are just bits of useful information about, the first one's about the faculty in general and how that fits into the sort of the national areas. So at the moment, they're trying to have a faculty across every integrated care system. The other aspect that's in the next level down is the Education Student Toolkit that's been launched on the Learning Hub. So this is a resource for educators and students with different examples of how you may take students, look at how you might have a blended approach to students, just a really good resource. So if you get a chance to have a look at it, please do. It does ask you to log on and set up an account, but then there's lots of resources on there about different topics. And then also just to promote the Pearl Awards. So this is just an award that we've set up recently about innovation and creativity and resilience about placement. So if anybody's doing a different kind of a placement, so if you guys did a leadership placement or did a hub and spoke approach and just had a student a couple of days a week, we could, you know, look at that and have that nomination put forward for the team or practice wherever you may be. So I can send the nomination form to Phil to pass out to everybody. But it's just a way of being recognised that you're doing something different, increasing placements and just having those different experiences for the students. And that's me done. So if anybody's got any questions.
Thanks very much, Lindsay. Yeah, I think it was just really useful to be aware of that there are faculties around in different systems as well, and that you know, particularly from a lot of your points of view, if you're an FCP, looking at that standardised approach to kind of becoming an advanced practitioner, and looking at sort of best practice across the board, and also just it's a platform to share good ideas and where things have worked well. So that's why I wanted to kind of bring it up in this meeting, because it's just something to be aware of. Like I said, obviously this is for the Lancashire South Cumbria one, but there are one, I think there's a GM, and I'm not sure about Cheshire and South Mersey, but there is.
Yes. Yeah.
Okay, so there's faculties in all the different systems. That's brilliant. Thank you very much, Lindsay.
No,
so the next presentation is a clinical one. It's a slightly different order to what was on your agenda. So it's Laura Ferran who's coming in and who's doing a presentation based around sort of back pain assessments in FCP. So I'll have to thank Laura, who's got to juggle this along with childcare issues and poorly daughter, I think. So I really appreciate you kind of managing to do this, Laura, and I'll pass you over to you.
Yeah, no problem. Thanks very much. Thanks to the other speakers as well for allowing things to rejuggle. She's currently being, she's quite poorly, but she's currently being housed at grandparents, and they're waiting a phone call for when she can arrive back again. So as soon as I'm done, so we can get her to bed. So thank you very much for letting me go first. I'll hopefully be able to listen to the other presentations when in the background. So I'll just share my presentation if it'll work. Just bear with me. So obviously once I share, I won't be able to see anyone or see anything if any hands go up or any comments come up. So if someone could just, if you just want to shout up, really, if I'm quite happy if anyone wants to interrupt and ask anything whilst we're going along, or obviously leave things to the end, that's totally fine with me. So I will just, and I'll try not to waffle for too long. I know I said it was 20 minutes, but I think it's probably going to be more like half an hour. So I will try not to waffle too much. Apologies if I do. Okay, so. Okay, can everyone see that?
Yes.
Hopefully it can. I'm going to make it. Hopefully make it into slideshow mode now. It should work for us all. And I'll just minimise that then, so I can't see anyone. So yeah, I'm. My name's Laura, as Phil's already said. I'm an advanced MSK practitioner and have been for about 3 years. And for the last just over a year, been working as a first contact physio in the St Helens area. So myself and my colleagues, I think there's 8 of us, have a hybrid role, like a split role between our AMP jobs and our FCP jobs. So we're not full time in either. Really, which is quite beneficial for a lot of reasons. Just before I went into low back pain, sort of in FCP and management and things, I just wanted to I did do a presentation to some postgrad physio students at MMU about just the FCP role in general, and one of the slides from there was just highlighting our role in primary care, and I thought it'd be quite useful to remind ourselves why we're doing what we're doing and why it's beneficial, really, before we go into the specifics of low back pain. So in all cases, really, it allows that patient to have that continued management in that GP or that primary care setting. Really, it is the easiest first point of access for most people in terms of accessing MSK advice and treatment, albeit, you know, a lot of people do struggle to get appointments with the GPs, but certainly it hopefully isn't as hard to get an appointment with an FCP. It should be in all cases and most cases a much shorter and more efficient pathway for everyone, just because you have got that expert advice at the beginning of that patient's journey, and they're not sort of seeing 2, 3, 4 or more different non-experts within the practice before they get to that right person or get that right referral, really. And we are perfectly placed to be promoting that wider NHS agenda within that general practice setting. So that's all your making every contact count stuff there, really. And of course, the GPs, well, hopefully GPs love us. They certainly do in St Helens on the whole, really, because it's hopefully freeing them up to see more appropriate things, really, for them to see. So I just wanted to say, I did have, I don't know how well this slide will be received. This is not GP bashing or anything like that. They do an absolute wonderful job. They are overworked. And this is why we are so crucial to being in that primary care setting to treat these MSK patients. But before FCP was a thing and working in MSK services, there was a couple of main pet peeves that I had in terms of primary care management of back pain. So we'd get referrals coming into to our physio service, really. And for me, these pet peeves would fall into two categories, really. One was the patients that were referred with like that 5-day, less sometimes even, history of low back pain. It's a first onset, they've got no ridiculous symptoms, things are already starting to improve. Regardless of that, an MRI may or may not have been ordered. I've seen that plenty of times before, and they've also been referred into an MSK spinal or a physio service. And one or two things quite often happens with these patients. They either don't show up for their appointment, or you see them or speak to them and they tell you that the back pain's got better, within another week or so. And in which case that is sort of a real waste of resources, really. Whereas if they'd have got that advice off the bat, things may have been different. Other services, investigations wouldn't have needed to been ordered or accessed. And then the other end of the scale is those patients who've had that real chronic history of low back pain. Sometimes multiple investigations, they've been told some really maybe inappropriate or using quite damaging language to describe what maybe has been seen on scans or x-rays, been managed with analgesics, but never really been referred to any kind of MSK service or physio service for any bespoke advice and the right advice, really. And these people sometimes would rock up and you'd be like, oh, if only I could have get my hands on you a little bit sooner, things might have been a bit different in terms of your management and outcomes and things. So these are sort of, when FCP became a thing, these were sort of, in terms of back pain, the main things I was looking to try and rectify, really, by getting to those patients before anyone else, if you will. So from working in FCP, and this is my own opinion now, I've not got any stats on this, I've not got any literature on this, but anecdotally, really, I find the majority of the low back pain patients that we see in FCP are either your first onset acute episodes that are going to get better quickly with the right advice and education, or those patients who have chronic low back pain, but they're experiencing maybe an episodic flare, and that's why they're consulting. Might have a history of previous input from a GP, plus or minus a multitude of things. They may have had previous physio or chiropractic. They may have had investigations. They may have significant psychosocial factors as well that may need addressing. And these are your general non-specific back pain group, and these should all be being managed with the NICE guidance, really. That's been recently updated about a year ago, really. And I'm not going to go through that. I would hope everyone is aware of the NICE guidance for managing low back pain and sciatica, and that is what we should be using to manage, whether we're in primary care or whether we're in an MSK service. This is how we should be managing this type of sort of normal group of patients, if you will. And with these patients that are non-specific, we're not worried about them. There's no red flags. There's going to be sort of certain categories that they're going to fall into in terms of their management. I'll just bring those up now. So some you might be managing in FCP with a couple of appointments, some advice, exercises, some social prescribing. Maybe they're a smoker and you might be referring them to the cessation services. They may need some help losing weight or maybe socially isolated, and you can refer them on to the appropriate services there. The other group of people, you're going to then from FCP refer them maybe to the local MSK physio service for a formal course of physio. So these are your patients that you don't think you know, are going to necessarily get better with just some one-off advice or 1 or 2 sessions that maybe are going to need to be reviewed. You might be wanting to add in some manual therapy to your exercise and psychosocial sort of treatment if that's appropriate. And then the third group of people are those that you're going to refer to other services potentially, whether that be secondary care pain clinic, your local chronic pain management services we've got, where a pain management program is run out of, or possibly a referral onto neurosurgery for a surgical opinion. So those are the people that we're not too worried about really. For those from that last box, from those needing, sometimes investigations are needed as a prerequisite for some of those referrals. So my advice would be, in terms of looking at thresholds for investigations, for those routine investigations, those patients should be referred to your local spine or your CATS team or your local AMP service, tier 2 service, whatever it's referred to, for that more in-depth assessment and then appropriate investigations and onward referral. That is in what we would sort of advise and how sort of the general rule we work to. And there are exceptions to that, which I'll speak to it down the line in some later slides really. And my general rule and our general rule is, if you're not concerned about any serious pathology, you should only consider investigating a patient if it's going to influence their management options. So this is a question I ask myself on a daily basis in my FCP and AMP role. Am I worried about this patient? If not, is an investigation at this stage going to change what management options I can offer this patient? And if the answer to that is no, then that is not going to be a useful investigation, and that is my decision sort of made there. And I would obviously reason that to the patient quite clearly, those reasons why. So then to come into sort of in FCP where that threshold then may change in terms of investigation, and we come to looking at more serious problems. Suspected cauda equina being one of them, and then other serious and specific causes of low back pain that I've sort of listed there, and I've tagged inflammatory disease onto that. Not being a life-threatening problem, but one thing that is quite often diagnosis is delayed significantly, and something we should all be more aware of now. So we're talking about your spondyloarthropathies there, and that is something that, you know, we can quite easily, in my opinion, investigate in FCP and refer on appropriate to the local rheumatology service without that patient necessarily needing to touch any kind of interface service, really. So just a pause there for a moment to say, in these cases, pathways are your best friend, and we have quite robust pathways in our service. And if you don't have pathways in your service, or links to a local tier 2 service or spinal service, or even to the physios in your local A&E, then I would certainly urge everyone to sort of talk to the clinical lead about that and really get those pathways set up and those links set up. Crucial, really, and you will come to rely on them. And there are quite often cases where we deviate from those pathways, but that is always quite well clinically reasoned and discussed, really. So pathways are your best friend. So just an example here, so one of the most common things that we will investigate in our FCP clinics is someone with back pain who has a history of cancer. So this is just a little example of the pathway that we follow for that. And you can see sort of tracking down that left side. So this is a patient with low back pain, with or without leg pain, who has a history of cancer. And if you come down the left side, we look at that being in combination with any other associated red flags, really. So looking at that index of suspicion for something serious being on the higher side. And when that's the case, we would look to do an urgent whole spine MRI and also a malignancy blood screen as per our protocol. And we sort of have a list of what blood tests we would order for that, really. And won't go into that because I know that's going to be covered this evening. And then on the other side, you've got those patients with a history of cancer with low back pain but have no other red flags. And in that scenario, we would look to then MRI the painful area, not the whole spine, but the painful area, and also do those blood screens. but there will be examples and there will be times when we may deviate from that pathway. So that's just a really good example of that. And I hope that sort of helps some people sort of with their thought processes, really. So just moving on to the other thing that we screen for, really quite common. We don't come across it a lot, but we do screen for it a lot in MSK services and FCP particularly. And the first thing I'll say about cord recliner is it is more common than you may think, and it is something that if you work in a spinal interface service, you do come across it. It's I think I remember, you know, being in uni and there's this thing, and I heard a podcast about this recently actually, and I can't remember where it was, and somebody else may be able to let everyone know, but they were talking about this whole, a GP only sees one case of cord recliner once in their whole career, and it's really, really, really rare. And I think now the thinking is, well, one, where has that come from? You know, can we actually find evidence for that anywhere? And two, it is probably a lot more common than you may think. So it should always be in the back of our minds. We all know that, and we should always now be following the new guidelines from the National Back Pain Pathway guidelines, the clinical network there. And we have a copy of that framework embedded in our cord recliner pathway, and it's something that I certainly refer to regularly, and our physios should, and we always direct them to that. And again, that's something I can share if people are not aware of that and want to be sent that. I can certainly do that. The thing I will say about cord recliner and when you're worried about patients with this is, if you are not sure, you must ask, whether that be a GP in your practice who is there on that day, whether it's an MSK practitioner in your local A&E. You know, ESP physios do work in most A&Es nowadays, or whether it's someone from the spinal interface service. But always ask. Our team are always running cases by each other. You know, what would you do with this patient? And if in doubt, always send to A&E, and always send them with a cover letter as well. That is my sort of musts in terms of cord recliner, really. One thing I will say is, and this is something I've learned in FCP, is safety netting it's arguably more important in FCP and primary care than maybe in a physio service. And that does come with a bit of a caveat, because it is really important in any setting, really. I guess where we sometimes fall into a false sense of security in MSK services, physio services, is we are quite commonly reviewing people in those services. They'll be seeing a physio for follow-up, or you'll be contacting them for follow-up. And what I've found and learned in FCP is that this isn't the case. And so that last bit of advice that you give the patient before they leave the room could be the most important thing that you ever say to them, really. So it can't be underestimated, safety netting. And it is something that I do with all of my patients now. Even, you know, it's got to be a quick sentence, such as, if you're no better in a month's time, come back to see me. If your symptoms get worse, come back to see me, or reconsult with one of the GPs if you can't get in. You know, something as simple as that. But we aren't following people up routinely a lot of the time in FCP, or I certainly don't. If the patient needs to come back, the ball is usually in their court to do so. And there isn't a time limit on that reconsultation period or that opt-in period, whether anyone else uses that in any other services. You know, we do have an opt-in pathway, really, in our physio services, whereas patients ring up to rebook their review appointments. But that's got to be within a certain time frame, and if it's beyond that, then, you know, they need to get referred back in. But in GP land, that isn't the case. You know, that reconsultation could be 6 months down the line for that same problem. So it might be a while before you see them again. And again, that last bit of information you give them could be the most important. Any safety netting you do needs to be very clearly explained and very clearly documented. You can't do one without the other. And that's for your benefit from a litigation point of view, and obviously the patient's benefit, obviously, because you're giving them advice. But for other practitioners as well, because what does quite often happen in GP land, again, is that although you tell a patient to come back and see you if this musculoskeletal problem isn't better, they might just ring up reception and get booked back in with a GP. And if you've got a clear plan laid out with what sort of your next steps were with that patient if things didn't improve, that should really help with their ongoing management, really. So in terms of cord requirement and safety net, I am going to go over a really brief case study that is one of my patients from very recently in FCP. So I'll just briefly go through this with you now. I'll try not to waffle on too much. This is a 33-year-old lady who's a nursery nurse. And she started with, when she consulted, she'd had a few months history of intermittent back pain with right-sided sciatica and some pins and needles in the lateral border of her right foot. So her leg symptoms were intermittent as well. She also had on top of that, and this is why she consulted, a 1-week history of an increase in the severity of her leg symptoms. So this pain was now constant. It was really severe. And voluntarily, she told me that she suddenly couldn't lift a heel up on that right side. She found that going on her tippy toes was quite difficult, and she'd have to be signed off for work as well. So she was booked in with me. She had no cord requirement symptoms. She was sleeping fine because the diazepam and the naproxen were sort of doing their job to an extent, even though she was still in severe pain. She was able to sleep. And this was her first episode. She'd never had this before. She'd never had any physio. Subsequently, she'd never had any investigations. She had no other red flags. She was in good health, non-smoker. So when she came in, she had a real antalgic gait, sort of quite classic of quite an acute sciatica. She was toe touch weight bearing on that side, limping quite a lot. She didn't like going into lumbar flexion, had a positive straight leg raise. She had some mild weakness with myotomal testing on the right L5-S1, but she had some more marked weakness in her S2 myotome, so she really struggled to sort of push up onto her toes on that right side compared to the left. S1 dermatome was reduced and her ankle reflex was absent. The others were fine. Babinski clonus were fine. So my plan at that stage was, this hasn't been going on for too long, or certainly the super severe symptoms haven't been going on for too long. So we agreed for some urgent face-to-face physio because of the severity of the symptoms and because she was off work with it as well. So that was pushed through as an urgent referral to physio rather than waiting a little bit longer to start that. I also, because of how much pain she was in, decided to refer her to the local interface clinic, CATS clinic, or our spinal clinic, and made sure that she was booked in with me. And this is where this dual role comes into play, really. Obviously, I knew her, and that was so that I could arrange an MR, lumbosacral spine, to look for that disc prolapse really for her. So I think I got her in within a week in my CATS clinic for me to arrange that investigation. I provided her with a patient information leaflet about sciatica and gave her some exercises. We had a very in-depth discussion about cord requirement. She was given all the relevant warnings and safety netting. And I also provided her with one of the little cord requirement warning cards that we should all be handing out to people. And she was sent on her way. I told her to continue with a pain relief regime and to obviously reconsult with the GP if that wasn't really becoming effective. So 2 days later, she developed some urinary urgency or increased frequency, I think, as well. And she had some perianal sensation loss. And she followed that safety net and advice and she went to A&E. She had an emergency MRI the same day. And I think I remember from the A&E notes, so objectively, she had good anal sphincter tone, that was fine. But she did have some perianal sensation loss. And I can't remember reading whether they did a bladder scan or not. But they scanned her the same day. But by this point, it's getting towards lunchtime, I think now, into the afternoon. And this is what it showed, really. So I'm sure most of you can see from there. And this, sorry, the patient's given the permission for me to use the pictures of the back, by the way, as well. But this is quite a large L5-S1 disc prolapse there. And there is a sequestered fragment as well. I'll get the report up in a second. So that's that view there. And then it's also quite clearly demonstrated on this view here. You can just see that bit of disc is just really quite large and is encroaching on a lot of things. So it's compressing the S1 nerve root, and it is also compressing the chord equina. So there's the sort of summary of the MR really. So that disc material is causing, it's obliterating the transiting right S1 nerve root, but it's also causing significant compression of the distal chord equina. So she was transferred the same day to the Walton Centre, which is our local tertiary neurosurgery hospital, and she underwent the next morning she underwent discectomy, emergency discectomy and decompression. So this wasn't that long ago, and she's now recovering from that surgery. She's still under our physio service. She's now got normal bladder function and normal perianal sensation. She has got some residual symptoms in that right leg, but those symptoms are improving, and her pain has significantly improved. And the most important thing with this is the patient was quite clear. She credits that clear safety net and advice that she was given at that FCP appointment with a reason for attending A&E. She sort of said that although those symptoms she developed are unusual, she's not sure she would have sought immediate medical attention for them had she not known the significance of that really and sought that help. So that is really for me the take home message from today, is that safety netting is so crucial. So going back to sort of coming away from chord equina now and going back to sort of what I said earlier about having that hybrid role and investigating, there are some sort of deviations from those general rules that I will go over with you, and I can't give sort of a black and white sort of list of things of when I would deviate from referring to, say, an interface service versus investigating in FCP. It's on its own merit really, but some sort of general things is that because we do this dual role of AMP and FCP, I'll just go back there. It is hard to dissociate those roles sometimes. And especially when we first started our FCP service, when we all went out into GP practices, I know all the AMPs I work with found it hard to sort of push those roles away from each other. It's nigh on impossible really, and to sort of switch your brain between those two roles. And what was quite critical in us navigating through that really is having that regular peer discussion with each other and regular MDTs, which we did have and continue to have. I think a lot of our decision making in FCP, a lot of my decision making is definitely it's dictated by having an awareness times of waiting times in our physio and AMP service. So there are things that maybe I would direct towards our AMP service or our CAT service for investigation, but because I'm aware of the waiting time being X number of weeks, I may say, you know what, I'll keep this patient in FCP and investigate them there. And sometimes that's a good thing to do, and sometimes maybe that's, you know, can overcomplicate things, and you think, oh, I wish I'd have referred them on really, because they do need managing in that spinal service environment. And it's having an awareness of obviously your capacity in your own FCP clinics as well. And that reasoning does change on a weekly basis. We do get a weekly report for waiting times really. But that's sort of the main thing that would make me change my mind whether I'm going to investigate someone is an awareness of maybe those waiting times. And I know not everyone will have that at all, especially if those services are quite separate. That's, I guess, very unique to our service in that we sit in both camps really. So just a brief note now about following up on results. You know, if you're ordering in FCP, you absolutely have to follow up on your results, regardless of whether you're referring that patient onto another service. I would ensure that you've got a robust system that works for your setup, your FCP setup, if you will, and that might vary from PCN to PCN that people work in. We personally use a colour-coded spreadsheet that we all use the same kind of spreadsheet, and that's checked, in most cases, that's checked weekly. And it's crucial that everyone uses the same system in one team, really. So if there's a group of you that cover one primary care network, you know, that will be quite useful to all use the same system. And you can all then have, if possible, we use a buddy system if anyone's on if anyone's sick or they're on annual leave. You know, if I know one of my colleagues is off sick, and they're going to be off sick for a little while, you know, we might email each other and or contact each other and say, do you need me to check your investigations for you? Is there anything that you need me to do there? In the case of urgent investigations in FCP, say for example bloods, and this is deviating away from spinal things now, but a good example is if you think someone's got PMR and you've sent them for bloods, and if you're not in that next day and you're not likely to be around when those results come back in, I would always, as a courtesy, pre-warn one or all of the GPs, depending on how big the practice is, or your GP mentor, to say, look, I'm worried about this patient may have this. I've ordered bloods, but I'm not in for another week. Can you look out for them? We're on EMIS in most of our practices, so it'll work in all GP practices that if results come back, it does get flagged up to someone. But I think as a courtesy, it's useful just to let people know, really, if that's the case. In the case of routine investigations in FCP, I'll do one of three things usually, and it depends on what I'm expecting that investigation to show. So it might be that I advise the patient that will quickly call them with the results, so not formally book an appointment. It may be that I do pre-book them appointment, i.e. 2 weeks later. Say for any X-ray results, for example, if that patient is super keen to see that X-ray or to have it explained to them, I might arrange to see them a couple of weeks later, get them to come in and go through those results with them. Where it will be a quick call is if I'm pretty convinced an investigation is going to show a certain pathology and we're just looking for the X-ray, say, to confirm that, then I might just say, look, I'll give you a quick call to say yay or nay to that. But we've already probably got the management plan in place for that problem. In terms of scans, which are going to take longer to come back, we can't pre-book or we can't book in advance into our FCP clinics too far. So I'll just tell those patients to book a follow-up appointment with me after they've had the scan and leave a couple of weeks so we can get the report back in time. And I'll obviously document that I've told them to do that in the notes. And obviously, again, an alert will get flagged up on the system if that result comes back. A GP or someone will always look at that and put a note on it, give instructions to admin on what to do. And on that note, sometimes because of that system that they have, which is a really good sort of fail-safe system, your investigations, albeit you're planning on following that patient up, might be intercepted by a GP or a nurse practitioner, and that might be completely unavoidable. It might even be the receptionist. Actually, I've got a good example recently. I sent a chap for a shoulder X-ray. I thought he had quite marked AC joint OA, and he was really struggling with it, and he wanted an injection, but I didn't know how bad it was, so I thought we'll get an X-ray to see whether we can get a needle in there, basically, and quite clearly said that I will follow him up with it. And the X-ray came back showing quite marked OA in his AC joint, which is completely fits with his problem and what we were expecting to find. But he's rung in the meantime, and the receptionist actually got it up and told him that it was fine and there wasn't anything on it. So he was quite surprised when I spoke to him, and he said, oh, there is something there then. So that's just something to be aware of. That obviously doesn't happen very, very often, but that sometimes may occur, really. So there's just a bit of a screenshot of an example of the spreadsheet that we use to follow patients up, really. And like I say, anything that's green is something that's been dealt with. We don't need to check. And then sort of yellowy orange things are things that I need to be more aware of or highlight more clearly and maybe look up more. And then obviously anything that's left blank is things that I've not had back yet or not looked up yet. So you obviously just have your own system, really. Just a very last slide that I'm going to chat to you about is just about when to get medical assessment, really. So it doesn't really fit in much with everything else that I've said so far, but what I will say about this is that it can be really difficult for patients sometimes to dissociate MSK and non-MSK symptoms. And as we know, lots of non-MSK things can masquerade as sort of physio problems, really. So, and if we find that difficult, you know, you really can't blame the patient for finding that difficult. With the nature of the FCP, if if it's working as it should, the system, a lot of these patients should be getting booked directly in with you from triage, really, either from an e-consult or from ringing reception at 8 o'clock in the morning, you know, however that patient normally accesses that. So then you are the first point of contact. So a lot of these times, you know, it may be a non-musculoskeletal problem that gets booked in with you. And for that reason, we do need to have, I found, a much broader awareness of other things, masqueraders, because in a lot of cases they've not been screened by a GP or a nurse practitioner first. I would always seek a medical assessment, whether that be, well, by a GP in practice, if you are suspicious of any non-MSK pathology, whether that's in the context of back pain, linked to that back pain directly or not, or in addition to it, you should always seek that medical assessment if you're a bit suspicious. And obviously, if you are very concerned, or if it's something life-threatening, it stands to reason that really that you send that patient to A&E or even ring 999 if you're really worried about that patient. And always liaise with a GP if they're on site or available. I know a lot of people may not have that luxury. Some people may do, but if they're there, you use them, really, would be my advice there. And I think that is it. So I'll just get rid of that and stop sharing with you all, and sort of open the floor up for some questions, really, if anyone's got anything they want to ask, or hopefully I can answer it. And if not, great.
Before, if anybody has any questions, obviously shout them out. But thanks very much, Laura. I think probably some of the key take-home messages for me is to make sure that everyone's aware of the sort of the national guidelines and NICE guidelines around back pain management, but also about your local pathways. And that's fine if you're working as a dual practitioner who understands the services already. But if you're an independent person or you're somebody new to the area, you're working 100% within FCP, really important to be aware of what are the local pathways. And it's really just a case of getting in contact with your local MSK or your CAT services or whatever it might be, so that you become aware of what those are. I think also the other thing is to be aware of the importance of safety netting, and also making sure that you make a record of that. And that's both for the important for the patient, for themselves, to make sure that there's a really clear understanding of what they need to do, but also it gives you a bit of security from a sort of a public liability point of view. And then the other thing is looking at how do you kind of check results. It's something which, it's very easy to do to order the investigation, but how do you know that's been followed up? And if you don't have a robust system in place, it's really easy to be missed. So that's something which I think is really important that is in place if you haven't got that already in place. Has anybody got any specific questions they want to ask Laura?
I think I've just seen something pop up, but then it's disappeared. Oh,
how many do you cover? How many practices do you cover? Sounds like an awesome service you work in.
Oh, very good. Yeah, thanks, Stuart. Yeah, I mean, it is, and that's credit to our clinical lead, really, and my colleagues. And we are a very tight-knit team, really. And if you are part of a team, I think that is sort of crucial. We're constantly, in touch with each other, asking each other questions and queries and things. But in terms of how many practices, that is a really good question. St Helens is split into 4 primary care networks, and we have got the contract for 3 of them, I think, or maybe 2.5. I personally cover 2 practices, and I work in those practices 1 day a week each. And there are 8 of us FCPs, and I think we all mostly cover 1 or 2 practices, so there are quite a few. If Barry's here, by the way, who I work with, one of my colleagues, he'll be able to actually tell us if he wants to, if he's there listening and he wants to. He's the guy with the numbers. He actually knows how many practices we cover, and we have just recently expanded into one of the other primary care networks. So we've just took on a couple more AMP FCP practitioners. Really, but hats off to anyone who works alone and solely in FCP, because I don't think I could do it full time. So I'm absolutely in awe of anyone who can do that, really. So, all right, yeah. So Stuart's just said there that you cover 7, so follow up is really difficult. So yeah, I imagine it will be really.
Okay. That's great. I think I'm just aware of timings, so just to let you know, if anybody's not looked in the chat, that I've put up the National Back Pain Pathway, which was mentioned by Laura, and so that the link is there. And unless anybody has any burning questions that they want to ask, then it's probably time to move on to the next presentation. Is that okay?
Mm-hmm.
Brilliant. Thanks ever so much, Laura. I appreciate it.
Thank you.
Hope your daughter feels better soon. So the next presenter is Joe Loads, who's team lead in rheumatology services as a physio. He's a trainee ACP and is in his second year, and he's going to talk to us about inflammatory back pain. Over to you, Joe.
Thanks, Phil. I'm just waiting for it to load up. Let me know. Has it come up full screen?
Yeah, we're up.
We're good. Mindful of time, Phil. When do you want me to box it off by? Because I can blitz through if you want me to. Crack on. You're on mute, Phil.
I won't help you in the instructions. Just crack on and we'll see how we get on with for timing.
There we go. So as Phil said, my name's Joe. I'm in the second year of my ACP at East Lancashire in rheumatology physiotherapy. So one of the modules we're doing in quality improvement, I've chose to pick on improving awareness, knowledge and screening practices within primary care, and whether this can be a step towards reducing time to diagnosis, which is part of the NAS national-led Back to Action campaign. So hopefully the outcomes from this is that I'll provide a wide understanding of the diagnosis of axial spondyloarthritis, AXPAR. Going to discuss screening for suspected AXPAR and different clinical tools that are available for you guys to use, and hopefully increase your knowledge and awareness of this screening within the FCP role. So within context, AS or AXPAR, as the umbrella term, is a low back pain. As we know, it's an autoimmune inflammatory arthritis that affects about 1 in 200 in the UK. And NICE have acknowledged that healthcare professionals don't always recognise signs and symptoms, and that can lead to substantial delays in diagnosis and therefore treatment. So roughly on the average UK is 8.5 years to diagnose from starting with the symptoms, and with an average age of 24, it starts quite young, and subsequently 59% of patients will go on to develop mental health problems, and I suspect a large part of that is due to the length of time they're struggling with pain, fatigue and stiffness and not knowing what's causing it. So I'm going to ask you all a favour now, if for those who have got smartphones, if you can scan the QR code, there's just a little baseline knowledge questionnaire through Menti. If you can go up on it, it just takes 2 secs. So if you can do a few drag and drops, just to score your current level of knowledge, what you perceive it as from 1 to 10. The results won't come up, so you don't need to be worried if you don't know anything about it, but hopefully some of you guys do. And if you all score it as 10, I can go get off here early and get some tea. So you just take a minute or two to sort that. Hopefully there's no problems with it.
It's worked fine for me.
Lovely. Right, we'll crack on. So time to diagnosis in the UK, 8.7 years, and that's sort of one of the highest to other countries around the world, with China having quite a low level of time to diagnosis, just to give you some context. So as part of the quality improvement, me and one of my colleagues went through 20 newly diagnosed patients with AXPAR. So we've got a database of them. So we found ones that had recently been diagnosed, and we dug through all the EMIS records to count how many consultations that they had before they came through to the service. So the average time to diagnosis was 7.7 years, and that's patients that have been diagnosed in sort of 2019 and 2020. And then as part of that, we looked at how many had been seen in primary care and how many had been seen in sort of a musculoskeletal interface. So within predominantly it was GPs that we looked at in primary care. There was a bigger delay in primary care than in our musculoskeletal service, with one of the highest being 16 appointments before they got referred through to rheumatology. So it just shows at what point in the pathway that this delay can occur. And initially I set up this QI to look at improving the knowledge of GPs and AMPs predominantly, but with the workforce transformation and the development of your guys' roles in FCP, you were going to be the guys that are picking them up. So as we know, there's some differentiators between inflammatory and mechanical back pain. However, it's not as black and white in this, and this is taken from NAS. So with inflammatory back pain, the age of onset can be less than 40 years. It can be insidious, less likely to be like an acute injury. The pain generally improves with exercise. Patients are better to keep moving, and they don't like being sat still, and they don't like being laid still in bed at night time. They get particular morning stiffness, but I appreciate some of your chronic mechanical back pains can as well. And the pain can sort of wake them up at the second part of the night. But typically what I see from my patients is that it's been in one position for a couple of hours before having to get up and stretch and move about before going back to bed. And as with mechanical lower back pain, it can be in any age of onset. It can be a variable onset, it can be acute injury. Pain may worsen with movement, but it can also improve with movement, which doesn't make it simple. But pain can often improve with rest. So that's some of the big differentiators, really. So there's quite a wide spectrum of spondyloarthropathies, and that's where the term AXPAR comes in rather than AS. So you've got your non-radiographic AXPAR, your ankylosing spondylitis, which are predominantly spinal involvement, and then under the other spondyloarthropathies, you've got your reactive arthritis that typically start after an infection, quite common with STDs, and they're more predominantly peripheral arthritis that you'll get with them. You've got your psoriatic arthritis as well. So if patients have got a history of psoriasis or psoriasis in the family, that's when you can consider whether they might be developing AXPAR as well. And also patients with inflammatory bowel disease, Crohn's and colitis fall under this HLA-B27 spectrum, so that these patients can develop AXPAR as well. So in the non-radiographic stage, essentially the X-ray of the SIJ will appear normal or meet the grade 1 and 2 of the modified New York criteria. But it can take quite a bit of time for radiographic change to occur. So that's always why X-ray is not always the best thing to do. Earlier forms of radiographic is when you start to see sort of sacroiliac changes, and that's sort of your grade 3s and grade 4s on your modified New York criteria. And the advanced forms is when you have got this ankylosing of the joints as well. So I'll talk a little bit about X-ray versus MRI later on. So as we said, the radiographic progression in the non-radiographic early stages, that's where your MRI is going to pick up the sacroiliitis, but it's only the point at which things ankylose that then becomes radiographic, which they pick up on X-rays, but that can take many time and years to develop, hence why these patients can have a long diagnosis time. So predominantly 50% of non-radiographic AXPAR patients are females, and typically the stats used to be like a 1-to-3 ratio of females to men, but we're seeing more and more in the literature now that it's a lot more common in females, and these patients are the ones that sort of get missed. 89% of patients with AXPAR have inflammatory back pain. What that basically means is it's a predominant symptom of this condition. And the literature also shows that both non-radiographic and AS patients suffer from a similar burden of disease, sort of pain and fatigue. So it's something to consider, really. So what are the common shared features? Inflammatory back pain, peripheral arthritis, enthesitis, dactylitis or sausage fingers. Other extra-articular ones are anterior uveitis or rhinitis. So anything up to 41%, some of the literature says that can be the first clinical manifestation of AXPAR, is that patients will be coming and reporting problems with flare-ups of uveitis that they've been treated for and won't link it with the back pain. So there's quite a lot of work that have gone into different ophthalmology services around the country, sort of advertised for that. So for when we look back at the GP records and the screening, you saw sort of back pain coded on EMIS, and then you saw uveitis, back pain, uveitis, and that can cause significant delays. And so the shared features, imaging changes of the sacroiliac joint and in the spine as well. So this is the New York criteria essentially. So it's only when you get to the grade 3s and 4s where you'll get the radiographic change. So that's where in primary care you might do an X-ray and it might look okay, but the patient may still have non-radiographic AXPAR, And then you've got the, have you got enough subjective and objective symptoms to warrant referring on to rheumatology, versus how many practices are going to be happy about you doing MRIs in primary care for this. So the ASAS criteria is one of the most validated criteria with the highest sensitivity and specificity. I always struggle to say that. So you'll have sacroiliitis present on imaging and one of the SPA features below, or the patient will be HLA-B27 positive and have 2 other features in order to warrant that. And if they meet this criteria, there's a good chance they've probably got it, and that warrants referral on to rheumatology services. So screening, how can we screen for these patients? So you may have seen on Instagram, Twitter, there's the ScreenDem acronym. It's one that I use, and it's sort of considering, does the patient have any skin problems, psoriasis, or family history of psoriasis? Do they have Crohn's and colitis? Is there a history of inflammatory bowel disease? Because a lot of these patients will have medications that are treated for Crohn's, and it also helps with the back pain symptoms. So sometimes it's quite hard to diagnose these patients as well. Relatives, is there a family history of axSpA or inflammatory arthritis? Like I said, with the eyes, uveitis, iritis, the stiffness, which we've talked about already. Is there any nail involvement, any thickening of the nails or nail pitting? Does the patient have sausage-like fingers, big swelling, dactylitis? That's quite common in psoriatic arthritis. Same with the enthesitis. And the last one is movement and medication. Does the patient respond really well to NSAIDs and exercise? So here's the extra-articular manifestations. In the top left, we've got the uveitis. On the second picture, we've got the dactylitis of the third toe on the right. You can see the plaque psoriasis on the elbow, and they have clear borders. And then you've got another nasty hand with different dactylitis there. And then the bottom 2 pictures on the left, you've got the pitting of the nails, which are only small little lines in the nails, and the onchylosing as well, which is sort of where the nail bed starts to discolour and fall off at the end. And they're typically linked with psoriatic arthritis. But the psoriatic arthritis are part of the HLA-B27 family, so they get spinal involvement as well. So one of the things we do use in rheumatology, and that it's quite a nice one to use in primary care as well, is the Schober's test, where you sort of mark the L4, L5 region, 5 centimetres below and 10 centimetres above. Ask the patients to touch the toes a couple of times and see how much movement they've actually got in the lumbar spine, because a lot of patients can reach down towards the floor, they'll have good posterior chain flexibility, but you want to know how much movement's actually coming from that lumbar spine, because that might guide you towards have they got an inflammatory back pain. So bloods, dependent on what's available locally and what your GPs are happy for you to order. The HLA-B27 antigen testing's present in 9 out of 10 patients. That's something that can increase that clinical specificity. However, 10% of patients can be negative, so it's not a rule out. Full blood count, your ESR and your CRP, noting they can be within normal range. Typically, the CRP has a higher clinical specificity than ESR, so that's something to look at. But again, the bloods can be normal. But if you are getting them raised, it's increasing that suspicion. So Rudverlate and SEPA sort of developed a diagnostic pyramid and looked at the different likelihood ratios based on what symptoms they present with. So the key ones are, if they've got grade 3 on the modified New York on the X-ray, it's very highly likely they've got axSpA, well, AS at that point. Sacroiliitis on MRI, he's got a 9 likelihood ratio. And then above that, you've got your HLA-B27 testing, family history, uveitis is quite high up there. So it's putting your subjective history and comparing them together with what you find and seeing sort of where they meet on this. And there's quite a lot of things on there, and it's quite difficult to do. So what then I'll talk about in a minute is one of the tools that's been developed by the University of Bath to make life a bit easier. But here again, it's Rudverlate and SEPA's specificity and sensitivity tests and the likelihood ratios. So your MRI test, your HLA-B27 are up there. Patient responding to anti-inflammatories and family history are sort of your highest scoring ones, with the uveitis as well. So the SPADE tool is spade.tool.co.uk. You can quickly search on it, and it's got tick boxes basically on what symptoms the patient has. So you can tick through them on each section. So it adds a lot of the things I've talked about earlier. And based on your assessment, it then generates a graph and sort of gives you a chart to say how likely it is that the patient might have a diagnosis of AXPAR. So it's quite an easy thing to use if you've done all your subjective, objective and tests, to pop in to then say, you know, look, does this patient need referring on to rheumatology? Imaging, so if it's suspected, this is the X-ray or MRI really. So non-radiographic is characterised by the active inflammation before the structural changes take place, and that can only be seen on MRI. 24% of patients with active AXPAR have no MRI sacroiliitis as well, or the lesions can be visible. So typically when an MRI is requested, we want the short tau inversion recovery, the STAIR imaging, and we want your T1 weighted MRI as well, because they're basically really good at picking up the bone marrow edema and any inflammatory changes. So if it's requested as a normal MRI, there's a good chance that they can be missed. So that's also something to be mindful of when you are requesting, that you make sure that you get these sequences ordered so that the radiologist knows what they're looking for and it's easier to see. So essentially from the screening summary, you need to do a good subjective history from your patient, consider the screen DEM acronym, routine blood count and HLA-B27 if it's available, your objective examination to see if there is any sort of stiffness, knowing the ASAS criteria, considering use of the spade tool because it's quite a quick thing to use, and then looking at what further imaging might be used based on the localities you've got and the other things in the sort of primary care networks. So management plan of these patients. So NSAIDs are sort of the first line management of this, and sort of NICE recommend, and the different guidelines recommend that you trial an NSAID for up to 2 to 4 weeks at its optimal dose and see if there's a clinical response, a significant clinical response. If not, consider switching the NSAID. And within that, you've got to consider the cardiovascular risks. So your COX-1 inhibitors like your naproxens have got less cardiovascular risk, but then you've also got to consider gastrointestinal involvement and potential renal toxicity with your patients if you are prescribing them, and considering appropriate PPI cover. If you were going to image these patients and they're on NSAIDs, there's no sort of literature to say otherwise, but it's quite commonly practiced that you stop the NSAIDs before you have the MRI done for at least 2 weeks, just in case they're treating the inflammation, and then you go to scan them and there's nothing there. Some of the other COX inhibitors they use are toricoxib, diclofenac, indomethacin and celecoxib as well, and referring on to physiotherapy. So once they hit the door in rheumatology, depending on what they've trialled already and based on what their imaging shows, they might consider that still exploring the first line management, referring to the physio team. But if not, the second line management is your disease modifying biologic drugs, which obviously you guys won't get involved with, but it just gives you an awareness of what happens at the other end. So these are your disease modifying anti-rheumatic drugs that just work on single molecules, and it's your tumor necrosis factor that they inhibit, because that's the large inflammatory driver in these patient populations. Outcome measures that we use in physios, they're ASQUAL and the BASDI, BASG, BASFI, that are patient-reported outcome measures with some objective ones. And there's a few further reading things that are on there. NAS have got a really good e-learning modules that run through all of this stuff again, that don't take too long to do, that I found really informative. And Versus Arthritis have got sort of a GALS assessment, which is quite a quick general musculoskeletal assessment, which is quite useful, I imagine, in your short appointments in FCP land. Before I get you to rescan your QR, I'll take some questions if there is any. Either people put their hands up or put it in the chat.
No one's got anything to say. I think it's a really brilliant presentation, Joe. Thanks very much. I think it's one of those areas which certainly a lot of people, a lot of physios, as well as primary care management, is unsure about. And I think the things which I've kind of picked up again, as we know, there's always often a really long delay. 8.5 years delay for actual diagnosis is pretty horrendous. I think it's important that we've got some really useful kind of sort of tools, if you like, to help us remind us. Things like the screen DEM acronym, I think, is a brilliant thing to have in place for your subjective history. So the ACES criteria looks great, and the Showbus test is easy, and the Spade tool as well. So, you know, even if you just use one or two of those, I think it has real increases your kind of clinical validity of your assessment, and hopefully increases your chance of getting an appropriate diagnosis and an earlier management. Let's see if we can reduce that 8.5-year wait by having more physios in primary care. Right, I think we've got Lisa. Yeah, we've got a hand up. Oh, you're on mute still, Lisa.
Yeah, no, can I just that's really great information, but I'm a patient with lived experience at the moment. I'm going through, I've been diagnosed with like rheumatoid arthritis, so now my knowledge of like rheumatoid from a patient point of view so I'm very empathetic now. I always was, but just for clinicians' point of view, and I didn't know this, and just to have some empathy with patients, your DMARDs can take such a long time to actually sort of like work, because I've had to be on like different ones for like 6 months, and actually you've got to give it 6 months, and even if it doesn't work, you've still got to put up with it and try it for 6 months, and then after 6 months you go on to another one, and after 6 months you go on to another one. So it's a really long process for your patients and things like that. So it's just something to bear in mind, like, you know, from frustration, sort of like, you know, mental health point of view, all those type of things. When you're treating like a rheumatoid patient, they all fall into play really, and things like that. So it's just for general information. May as well share my pain with you, and things. So just thought I'd mention that.
Thanks, Lisa. I think that's probably really useful to have that kind of personal experience. And if it takes a long time to kind of get the management right, it's even even more important to kind of get the diagnosis earlier. So I think it's been a really useful, certainly for me, and I'm sure for a lot of people, a really useful presentation. And like I say, some really easy actual tools to use just to be a bit more specific. That's great.
Can I ask you all to rescan the QR code for a minute, if that's all right? And
not that you've got an MSc presentation to do or anything like that.
No, not at all.
So I'll give everybody a minute just to get that done, and then we'll move on to Dave's presentation. Now I know we're behind on timings by quite a bit. So what we will do, I think, is just continue as normal. Hopefully people who can stay on, but bear in mind, if you have to get off, then we are recording it, and we'll send it out with the minutes along with all the presentations. So as long as there's no really big objections, then we'll move on to Dave. So Dave Booth's one of the ESPs at East Lancashire Hospital. He's a very experienced extended scope practitioner, and he's going to sort of talk to us a bit about blood tests. I've made him promise to keep things relatively simple. He's got the brain the size of sort of NASA, so we need to try and keep things as simple as possible. But we're looking forward to this, I'm sure.
Cheers, Phil. Thanks for that. Can people see that? Is it sharing?
Yeah, perfect.
Right. Okay. Yeah, a few people have introduced themselves. I'll have a quick introduction for myself. I've been an advanced clinical practitioner for about 19 years, and I've done FCP for about 5, just 1 day a week generally at the moment. But I do have a bit of an idea on these kind of things, just a little bit. We'll see what we can do. So Phil asked us to have a chat about blood tests, mainly in a FCP role. So hopefully we're going to make it not too much, and I want it to be quite interactive, so I've only got a few slides, and I definitely wouldn't mind people just jumping in at different points. Just shout out if you want to say something. I'm going to ask questions and people can jump in. If people don't answer, I'll just carry on as I am. So obviously I can't see anybody at the moment because this is filling my whole screen, unfortunately, but I'm sure someone can just shout out if they need it. Can everybody hear me? Can we hear it well? I hope so.
Yeah, we're all good, Dave.
Brilliant.
Yep,
all right. First thing is peripheral neuropathy. So, I mean, realistically, before we start considering why we do a blood test, we need to really have a good idea of what the condition is. So obviously in peripheral neuropathy should be managed and treated and diagnosed generally in a primary care. So anybody want to give me an idea of peripheral neuropathy, what it is? Give you 5 or no? I'm sure you all do know. I mean, a peripheral neuropathy is effectively where you end up with damage to the neurons, often the end elements of the nerve, but it can be through the myelin sheath, etc. There's numerous types of neuropathy, and they can come on from numerous types of reasons. Primary symptoms would be more of a pain, pins and needles, burning type sensation, more in the peripheries in most commonly, though there are types where it's more of a things like diabetic amyotrophies, etc. And you can have diabetic polyradiculopathies versions of this as well, where you can end up with things like leg pain, thigh pain, weakness. So there is quite a few variations to this. So sometimes when somebody just has those very vague leg pains that you can't seem to work out what they are, it could be vascular, it could be neurogenic from the spine, but it could be a peripheral neuropathy for an unknown reason or a reason. In a lot of cases, there is a good reason for peripheral neuropathy, and we're just going to go through some blood tests, but obviously we'll discuss some of the common other ones that you necessarily wouldn't pick up on a blood test. Alcohol, very, very common reason for a peripheral neuropathy. I unfortunately see numerous ones like this in practice, both in FCP and in musculoskeletal clinics. And somebody just, sometimes it's worth quizzing somebody on this. And if somebody is honest, they will tell you. I had one of this last couple of weeks, and I said, well, look, how much do you drink? He went, about 5 to 8 pints a night. Is that every night? Yeah, a bit more on the weekend. How long have you been doing that for? 40 years. So we ended up doing some blood tests anyway, but predominantly that's the most likely reason. Chemotherapy is a common reason as well, especially, but some different types of chemotherapy are variants, but some people often make a recovery following this. So common things you might consider in blood tests: HbA1c, which is for diabetes. I'm sure everybody knows that. Do people know what the HbA1c is actually measuring though? Anybody? Please tell me. No? Oh,
yes, is it the blood cells?
Go on, whoever that was. Go on.
It's
Two of you.
The glucose stuck to the red blood cells, is it not?
It is, yep. It's glycolytic red hemoglobin. So the HB is the hemoglobin. And how long does a hemoglobin molecule live for on average?
3 months.
Up to 3 months, yeah. So when somebody measures the HbA1c, they are looking at the approximation of the glycolized hemoglobin within the blood. So by measuring it, even you're working in a GP practice, if that person has had an HbA1c in the last 3 months, measuring it again too early will not necessarily give you an altered value. So that's why you'll always see them at least 3 months apart, sometimes longer. If somebody's got a fairly well-controlled diabetes, it'll be longer. So it's just something to consider. Diabetes obviously damages the nerves. It damages pretty much every cell in the body. So it is always something to bring up with somebody if they aren't controlling it well. Thyroid. So hypothyroidism can cause nerve damage. As it says on here, I looked up quite a few things because I thought, well, I'm not sure how thyroid actually affects peripheral neuropathy. I couldn't really find any good answers. So the best one ended up saying it's believed that it's probably because of fluid retention and swollen tissues exerting pressure on peripheral nerves. So I've learned something new doing my own studies. So thyroid, so T4 TSH, worth considering. B12. B12 deficiencies can damage the myelin sheath, which surrounds and protects the nerve. So people with a B12 deficiency may often have pernicious anemia. If it's not well managed, they could be having neurogenic and peripheral neuropathy type symptoms. So again, someone with extreme exhaustion, tiredness, tired all the time, as you'll often hear it seen on GP records, TAT, and peripheral neuropathy type symptoms, that might be worth thinking about and considering. These are probably your main things, because the other things you'll be looking at is like metals in the blood and autoimmune and inflammatory. Now, autoimmune inflammatory, you probably wouldn't go as a first line unless the person was starting to consider telling you about they have inflammatory symptoms in the joints as well, or a lot of things that Joe was going over in the last presentation. But sometimes when you come through all these, you end up finding that nothing else is giving an answer, and this person may have a vasculitis. So again, Whether you put an ESR in there, a CRP, it'd be up to you. It depends on your own systems. It depends on what your local GPs would do. Majority of GPs would probably just do an HbA1c and a TSH generally. Unless there's tiredness, they probably wouldn't do a B12. They wouldn't go for metals in the blood generally, and I don't think we would in many cases, though obviously if it's your local GP practice and they would, then you might consider it. And autoimmune inflammatory, if there's other things linking towards that, again, you'd probably add those in. But see what your practice does if you're working in that area. But also consider those other reasons, alcohol, etc., chemotherapy, and age in some people's cases. Right, because that's me done on peripheral neuropathy. I just want to get anybody want to just discuss about anything on that, anything their experiences, anything at all, or should we leave it to the end? The silence.
The next one, Dave.
Silence says leave it to the end, I think. Okay, so the next thing we're looking at is bone health. So bone health, you might want to consider a bone profile, calcium and the ALK-phos, alkaline phosphatase in the blood. So calcium levels, obviously, it's calcium itself, and you get the adjusted calcium quite often in blood tests. With the ALK-phos, this is released by bone. It's within lots of different organs in the body. It's an enzyme. It's in the liver, bone, and numerous other things. So damage to any of those areas will release this enzyme. So it's commonly considered in liver damage, but it can also be considered in bone damage. So obviously, if you just got a broken bone, you get raised calcium and ALK-phos. If you have liver damage, you'll get a raised ALK-phos. So it's not guaranteeing you've got a bone pathology, but it is obviously consideration of something. So that's not always telling you everything, but it might give you some highlights that there's something going on in the bone. Renal. So renal impairments, severe renal impairment can cause an osteodystrophy. This can cause osteomalacia, osteonecrosis, and pathological fractures. So somebody who's got like a chronic stage 3, stage 4 renal failure, it's something always to consider that they may have bone-related issues. So often, a lot of times, people might add in a bone profile in there. But it's also worth, when you're looking at bone and renal profile as well, to consider, especially in an elderly patient. If you already know they've got renal failure, then it's something to consider as an element towards that. Parathyroid. Does anybody know what parathyroid hormone does? I'll tell you if you don't, but just wondering what people know.
Controls the levels of calcium in your blood.
Oh, we've got a very bright person here. So I set 2 out of 2. Yes. So what happens is it works on calcium and phosphate levels in the blood. As one raises too high, if the calcium is too low, parathyroid hormone will be released. Parathyroid hormones then encourage the body to release calcium out of the bone. If there is, say, a parathyroid tumor, usually an adenoma, the body will produce too much parathyroid hormone. This will continually release calcium out of the bone, causing bone deficiencies, and they often find this thing called a Brown's tumor, which is just a lytic lesion on a bone on an X-ray. So it's just a low area of calcium deposits within the bone because it's all been released due to high levels of parathyroid. So then somebody who has a parathyroidectomy often then has low parathyroid levels, and we haven't really got a way of treating that. So often they're just given vitamin D and calcium. It also works on the vitamin D as well. There's quite a bit of a complex relationship with parathyroid, vitamin D, and all these different things as well. But the simple aspect is your body needs more calcium. Parathyroid release gives you more calcium, but it gets it generally out of the bone. If there's too much parathyroid, your body will release too much calcium continuously out of the bone. So you'd see an increased level of parathyroid hormone, but also an increased level of calcium. If there is just a lot of calcium in the body, but the parathyroid is normal, then the person may be having too much calcium in the diet, or there's some other reason. The final option would be too low, high parathyroid but low calcium. This is or normal calcium, sorry. So high parathyroid and normal calcium would not necessarily be a parathyroid problem, it's a low calcium problem, because your body is releasing more parathyroid to get that calcium. Can still cause the bone issues, but that person is deficient in calcium. So in that regard, this could be a vitamin D deficiency, a malnutrition, some form of malabsorption element, anorexia, bulimic, all those kind of things as well. So he's trying to think a little bit wider sometimes when you are finding these results and even considering the test. But that's where your GP's very good at these kind of things. So you might be wanting to consider a chat with them at any point within this. Is that okay? Obviously, any questions on that we'll get down to at the end, and we can have hopefully a general consensus. We've got somebody here who's probably very knowledgeable on this as well. Vitamin D. There is a very strong relationship with vitamin D and calcium. Body doesn't really absorb calcium without vitamin D. It also links with the parathyroid hormone, and all these things could turn inactive vitamin D into active vitamin D. So there's a nice link between all these things together, and they all work as a team to try and actually maintain the bone health, calcium levels in the body. So low vitamin D levels can cause osteomalacia, which is like weakening, thinning, softening of the bones. This can cause bone deformities in children and teens. In adults, it's more likely to cause fractures and bone pain. You often would see a raised calcium and alk phos in these kind of elements. Vitamin D, as we know, is absorbed by sunlight, but also from lots of different types of food. Not always a blood test done as much. Some GP practices won't do it very often because it's a fairly expensive test, and sometimes if they assume the person's got vitamin D deficiency, they'll just put them on vitamin D supplementation. So sometimes it will just be done as a preventative measure.
Dave, somebody's got their hand up. I'm not quite sure who it is.
Oh, I'm sorry.
But there's
sorry,
a hand.
I can't see hands. I'm really sorry.
Has anybody got a question?
Hi, this is me, Ashri. I'm sorry if you've already mentioned this. Could you maybe explain a bit how a renal failure can lead to osteomalacia? Is it something related to the parathyroid hormone regulation, because kidney and parathyroid hormone works quite closely, or?
Yeah, there is quite a link between all these elements. Renal failure is effectively, as much as anything, it's just your body like struggling to get rid of toxic elements as well. So again, your body then can build up different amount of chemicals, etc., in the body. So then your body has to work harder to get rid of them. This can cause some issues. To tell you the truth, exactly how it works, I'd have to look it up to tell you the truth. I'm very, very sorry about that. Not really something I really thought on, but it's just something I do know of. I can happily pick it up before the questions at the end, and I can definitely have it open for you if that's what you'd like, if you'd like to.
That's fine, thank you. And just a second point regarding the alkaline phosphate. So if somebody had a blood test, and especially female patient, menopausal patient, if their in the bone profile alkaline phosphate is abnormal, and in the liver function test the alkaline phosphate is in the bone profile the alkaline phosphate is abnormal, and in the liver profile the alkaline phosphate is normal. So can we then kind of assume or provisionally think that it could be potentially a bone problem?
So if they're both normal?
So abnormal in bone profile.
It'd be the same in both, because it's just measuring it within the blood. So it's been released into the blood. They don't know what it released it, being an enzyme. Something's been damaged or gone through damage, and it's releasing this enzyme in the blood. And it's in quite a few different. I just know it's in the liver and bone. I can actually look up where it is in other things as well, but it's in numerous other organs as well. So it just tells you there's something along those lines. If you then saw a raise, you'd have to start putting it together with other, bits and bats going on in that regard as well to try and get that answer. So once again, it might be more back to a GP for that kind of thing because it's more their field.
Thank you. Thanks.
I think it's just obviously where we're at is as a physiotherapist, no matter how experienced, we haven't got all those years or decades of medical experience and blood test experience a GP has. And I think it is always considering making sure that when you think, not sure about this at all, really don't know, you talk to them. I think what we're trying to do here is trying not to just throw every single test at each patient It's also trying to consider which tests may be appropriate and may not be, but put it, because we don't want to just throw everything. If you start throwing lots and lots, I'm going to use a cleaner analogy. Throw a lot of mud at a wall, you get some of it sticks. I know there's a less clean analogy than that, but if you throw enough, if you send enough tests for people, you're going to get stuff that's going to come back positive. So it's making sure you don't just throw everything at everybody. It's thinking about why you will and why you might not. Check GP's records. They may have had these tests done. There might be a trend for all that. These are all very important things to consider. If there is a trend that is going up, you might be more concerned and you might be wanting to get that test done. If the blood test is static and it's always been at that level, look into the GP's notes and see why, what did they consider at that time. If you're not sure, have a chat with one of them. And I think one of the things you do well is you learn a lot about blood tests by just quizzing someone very experienced, which is a GP that's one of their big things realistically. So I think it is a useful thing to do. If you're not sure, do that. It's just trying not to throw blood tests at people on a regular basis. So I think unless you're very experienced, if you start seeing abnormal raised calcium out phos, you wouldn't dive into a parathyroid. You might chat with a GP. You wouldn't just give a vitamin D either. I'd have a chat with a GP about it. This is just really to give us an idea of what kind of things could be causing this. So I think until you're experienced, work on that. I mean, it's rare I would send for a parathyroid, and I've been doing this kind of field for 19 years, 20 years. So even then, I very rarely do. It's usually when you find an abnormality on an X-ray. Okay.
We've got another question from Judith.
I'm very sorry.
Quickly.
Yep.
So it just says, could you expect other abnormal liver results if it was purely liver?
Yeah, generally you're going to start thinking that. You're thinking with liver, you're thinking creatinine levels is one of the first things. So obviously you would be expecting multitude of changes. So it'd be very rare to just, from my experience, other people here might give us different experiences. None of us are, I'm not a medic, so I can't give you a definitive, but I don't think I've ever seen an ALK phos raise on its own from a liver dysfunction without anything else there when I've talked to one of the doctors in our practice. Has anybody had any experience of something different? Take it. No.
So we'll move on to the next slide. That's great.
Yeah,
cheers,
personal experience, I've not seen that myself. So okay, let me get on to the next slide. Okay, this is just something to have a quick look over. If you're considering osteomalacia, I'm not going to go through all this. It's just to have a quick look over. These are a multitude of things that can have an element to osteomalacia. The things to really consider is vitamin D deficient diet, malabsorption, alcoholism, and certain types of drugs realistically, but you don't need to know which these are. Again, it's just thinking if somebody has these kind of elements, it's multifaceted sometimes. So this person might have reasonable vitamin D, but they may have other issues that's causing it. Right, last topic. Now we went on to serious pathology. Now, when we're looking at this kind of thing, it's obviously what are we classing as serious pathology? Now we had quite a good element of this in the first discussion, and obviously serious pathology is quite widespread. Cancers, infections, it definitely cause some form of traumas would be classed as a serious pathology, and some elements we may consider inflammatory changes depending on the severity. But realistically, what can we get out of blood tests for serious pathology? So let's consider cancers. What kind of cancers do blood tests give us an answer to? Does anybody know what type of cancers blood tests are very helpful on?
Myeloma?
Myeloma, yeah, myeloma definitely. I mean, generally it's blood cancers. So myeloma, lymphoma, and leukemia. Those are your primary ones. It would tell you. It might give you a definite defining thing too. It doesn't necessarily come up positive with metastatic bone cancers, for example, which is your primary finding. The most common type of cancer in the bone is a metastasis from another cancer, primary malignant cancer. So it may find something, but it may not. So completely normal blood tests are not going to give us a definitive there is no cancer going on. Abnormal blood tests also are not telling us there's definitely a cancer there. So blood tests are part of the picture, and that's what we've always got to consider. Obviously, if someone's had a pathological fracture due to something, then yes, you would find that, but they'd obviously be giving you a lot more symptoms than that alone. So blood tests can give us some answers if it's a blood-related disorder, and in an MSK practitioner, the only one we should be really considering and seeing would be a myeloma, and I will discuss that further on. But it's not a rule out of cancers, unfortunately. There is other types that are very specific cancer markers. Rarely we would consider this in an FCP or any MSK role. The only one that I think is sometimes useful is a PSA, so prostate-specific antigen, especially in somebody with back pelvis pains, a male of a certain age, especially if they're saying they've got urination issues. Adding in a PSA may not be that bad, but again, work on your own, work within your GP practice and see what they do. So do normal blood tests rule out a serious pathology? So, I mean, we could have a consensus on this. Not realistically, not for definite. So again, it depends on where within a serious pathology is, what type of serious pathology it is. Even in an infection, you may not get the levels you expect. For example, a spinal infection, such as an osteomyelitis, it's about 90% of people will have abnormal blood tests on testing. So not everybody will. At some point they definitely will, but not always 100% all the time. So it doesn't rule it out 100%. So again, if you get normal blood tests but you're still concerned about this person, it's worth discussing it with somebody else. They might then decide you want to bring this person back and do repeat testing. So it's back to, as was said in the first discussion, safety net. Normal test doesn't mean you've got a complete guarantee you don't have something. If that person is crying out red flags and you've done the testing and they've come back okay, it doesn't mean that that is 100% clear on that. It just means that that day the tests were not showing up something. So just be a bit cautious on normal results. The same thing, abnormal results don't always tell you you've got something serious. Some people just have very abnormal results. And also any abnormal results, you're not sure of, definitely discuss it 100% every single time. And if you're brand new to it, I discuss abnormal results every time, whether you are sure or not. So when we're talking about inflammation, we're looking at ESR, CRP. So when we realistically, it's thinking about what does the ESR and the CRP tell us? So what is an ESR, anybody? I'm trying to see if
it's how fast red blood cells sink.
Yeah,
sedimentation rate.
Sedimentation rate, exactly. But why is this sedimentation rate altered in inflammation? Can anybody give me the answer to that? Well, effectively, it's your body. Sorry, go on.
No.
That's okay. Body releases a lot of fibrinogen within an inflammatory process. This makes the cells in the blood pull together, so it makes the sedimentation rate alter. It can also alter for numerous other reasons, anemia, age, etc. There's many reasons. Because you're looking at that and you've got to have this reaction of the fibrinogen being released, ESR doesn't shoot up with an infection or inflammation. It will go up gradually over time, and it will also settle down gradually over time. The CRP is a C-reactive protein. It's when there's cell death, it's a binding element. So it shows that there's some kind of cell death going on somewhere in the body, commonly from inflammation or infection, but it can be due to lots of other reasons. So again, but it's very quick reactive. I think it's within 2 hours you should see an increase from an inflammatory reaction. So what you generally will see when somebody goes through inflammation is the CRP will go up quickly and ESR might be normal. After a period of time, when it's fully inflamed, you'll end up with the ESR, CRP both raised. Then the CRP will drop down, but the ESR will drop down gradually a lot slower afterwards. So when you do get some blood tests back for inflammation, and there's a raised CRP and a normal ESR, you could be at the start of an inflammatory process. If you see a normal CRP and a raised ESR, have they had an inflammatory process, or is it a completely separate reason for the ESR being raised, which causes numerous? Obesity can raise both of these. So again, it's checking the trends once again. Is there a reason for it? Have they got symptoms that indicate it? Because once again, if you put an ESR and a CRP for every single patient you see who has back pain, you'll end up with lots of positives. So it's being sure you're doing the right thing, the right reasons. And if you're not sure this is a learning element, talk to the GPs, your mentors, colleagues, just to get a consensus what you think's worthwhile. Whenever you would do an ESR or CRP, I would always do an FBC, a full blood count. Primary reason, you're looking for infection. So if you end up with a raised ESR or CRP and you have a raised white cell count, neutrophils, you can then go in along more of an infection element. So it might be something completely separate. Doesn't tell you where the infection is or the inflammation is, it just tells you there's an inflammatory or infection element in the body showing up in the blood. Is that okay to everybody? Hopefully. Now then, the one thing that Phil said, one of the blood cancers is a multiple myeloma. So multiple myeloma effectively is a plasmacytoma or multiple plasmacytomas. So it's a blood-related disorder and bone marrow. Your primary test for this would be a serum of protein electrophoresis and a Benz-Jones protein. Urine analysis. A lot of the hematology pathologists will do a free light chain assay, which is a much more specific test for this, looking at the free light chains in the blood or the urine. But generally, between the electrophoresis and the Benz-Jones protein, you're going to pick up these quite commonly. When would you consider this? Middle-aged to older person with bone pain, spine, ribs would be the commonest areas, but it can be in other areas as well. They also have the CRAB, an acronym. CRAB is C, meaning hypercalcemia, R, renal involvement, A, anemia, B, bone. And with the electrophoresis, you'll get immunoglobulins. The commonest immunoglobulin is IgG, then it's IgA, then IgM. But you don't need to be knowing that. You're looking for a paraprotein, a single protein, not a paraprotein. You're looking for a single protein being raised for this kind of thing, because generally it is one of those immunoglobulins is being activated. It's usually not multiple ones. If it's multiple ones, it's often a very different process going on in the body. So serum electrophoresis can also be used in inflammation. I'm sure Joe would say you'll see that quite often used in rheumatology, and it's quite a good sign of inflammation going on in the body. It can be a sign of infection, but it can also be a sign of specifics. Would you do this within GP practice? Again, I think it's chatting with your GP mentors, etc., and everything like that to see what they would consider. So when you get a patient you're a bit concerned about, these are the things you might consider. See what the GPs feel in your practice. They might say, I will see that patient for you if you've got any concerns. They might advise you on the blood tests. Once again, throw loads of blood tests at somebody, you're going to find stuff. We don't want to just you'll just cause a lot of headaches for the GPs. So I think when you're not fully sure, it's always have a chat with your mentor. I'm sure most of you guys have mentors in this regard. If you do get abnormal results, chat it through, discuss it through. Remember, we are physios, not medics. So obviously we've got to know our limitations. I've done 20 years of this and I still know my definite limitations on blood tests. And I think it's just trying to build up some skills as you go along. So, any further questions?
That's great, Dave. Thanks very much for that. So there's just a couple of things which have come up. So Lindsay has talked about the fact that platelet count is a good indicator for bone health as well. And that we've got about, how about CA125? Does many primary care consider doing
cancer
this?
Markers. Yeah, cancer markers are definitely one. But again, you've got to sit there thinking, which cancer markers are you going to look at? Why would you be looking at this? Which is the cancer marker I was saying I would probably do would be a PSA only. I don't think I'd do anything different than the PSA. Sorry, I'm sharing too many different things here. So I would probably keep to a PSA personally, if that. But again, it's considering what your own practice would do in that area. So yes, you can start looking into that, but I think that's moving into a medic side of things rather than an FCP role. So again, it depends on what your FCP role is, how it's been devised. So the only cancer marker I would personally ever use is a PSA. But again, it's within your own practice what they feel that they have developed for you, what they want you to be doing. So I do think that's a relevant thing.
Yeah. I think probably the key message from my point of view is to have a bit of a better understanding as to what you could measure and why you might measure it, but always to be aware of where your limitations are, and also to, most of your tests that you get back, you may well want to kind of discuss those with your GP or with your medic support, and that's really important to kind of, so as you say, it's something which you don't have to get involved in. If you're concerned or worried, you can get the medical team to kind of take some of those blood tests. If you're happy to do it, then you've got to think about why you're doing it and what to do, and being a bit more specific. And if they come back abnormal, then a lot, I think even when you are pretty confident, there should be at least a courtesy message or discussion with your GP support team. So I think that's really important. I think some people have found the sort of the differentiation between CRP and ESR really helpful. To understand sort of which one sort of comes, your CRP being your first indicator and reacts very quickly. ESR is a bit of a slower response and goes down a bit slower. So I think a few people have found that helpful, but hopefully people have found that a useful presentation.
I've got I did find this stuff on the renal osteodystrophy. If people just want that very quickly gone over, I don't know if people want it because I was asked about that.
I think probably with the time, I think we'll leave it at that for now, Dave. But thanks very much for the offer.
No problems at all.
But yeah, we'll kind of wrap it up, I think, tonight. Appreciate everybody who's actually stayed on a little bit longer. Hopefully you've found that useful. If there are any specific topics that you guys want to kind of be sort of addressed next time, then please give me a shout. Just email me, and I'm happy for you to kind of put up some suggestions. And then finally, if you look on the agenda, look at the sort of the dates for the next set of meetings is at the bottom. So I've been aware that they've been a little bit sporadic recently, for the last few meetings. So we've got them all set up over the next kind of four meetings over sort of 2022. So keep an eye out on those, but we will send out invitations later down the line. Summer?
I don't know if this is something I've just crossed paths with on the emails you sent across. Were you going to cover the paramedic role in this meeting today, Bill?
No.
No. Okay, it must be an attachment that was in one of the emails. I saw it come up and I'm like, where do I need to embed this? Sorry.
No, don't worry about the paramedics. That's separate. Brilliant. Well, in that case, I'll let everybody enjoy their evening. Thanks very much. I said hopefully it's been useful. And I appreciate everybody logging in, and hopefully we'll see you. I think the next meeting's planned for the 12th of January, so hopefully I will see you all then. If the minutes go out and you want to pass them on to anybody, including the video or the recording, then please feel free to share it far and wide, and encourage anybody who isn't on the group who's an FCP to join, and by sending their email details to Summer, and then she'll add you to the list. Brilliant. Have a great night, guys. Cheers, Summer. Absolutely brilliant.
Thank you. That was brilliant. Well done, everyone. Cheers.
All right. You take care. Cheers, Al. Bye-bye.